Good evening, and thank you for joining today's webinar, COVID-19 and the Liver, the Trainee and Early Career Experience in Hepatology during COVID-19. My name is Bilal Hamid, and I'm pleased to be moderating today's webinar. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. This webinar is being brought to you by AASLD and it's over 6,700 members. Our members are instrumental in creating exceptional educational content, such as this webinar tonight, and invite all of you to join us. You can play a vital role in bringing liver disease and treatment to the forefront and take advantage of many member benefits we offer. Please visit asld.org to learn about becoming a trainee member. And also, I would encourage you to register for our upcoming liver meeting. My name is Bilal Hamid. I am the Associate Professor of Medicine and the past Program Director of Hepatology Fellowship Training, and currently the Hepatology Clinic Chief. I will be moderating. We have a very interesting and impressive agenda. I will be starting with introduction, and then we have broken this presentation into two parts. The first part will be focused on impact of COVID-19 on the trainee hepatology educational experience, which will be presented by Dr. Ani Kardashian, and followed by, we have a panel discussion. The next part, we will be focusing on impact of COVID-19 on hepatology practice and job prospect, and will be presented by Dr. Vinay Sundram. This will be followed again by panel discussion. You are encouraged to submit your questions throughout today's presentation using the Q&A box at the top or at the bottom of your screen. We will answer as many questions submitted to the Q&A box as time permits after the formal presentations. We will not be taking any verbal questions during today's webinar. Dr. Ani Kardashian would be the first presenter, and she is currently starting her faculty position at USC and finished a hepatology fellowship at UCSF in June. Dr. Vinay Sundram will be our second presenter, and he is also the chair-elect for AASLD Membership and Mentorship Committee. We have a very impressive panelists with their experience, and starting with Dr. Teresa Chang, who is the program director at Mount Sinai University, followed by Dr. Allison Fox, who is also the Associated Designated Institutional Officer of Graduate Medical Education at Columbia University, or Dr. Australian, who is the GI Chief at UCLA, Dr. Hersherov, who is the current Hepatology Fellow at Northwestern University, and then Dr. Jorge Marrero, who is the Director of Liver Transplantation at University of Texas Southwestern. I would like to thank our Clinical Oversight Subcommittee, who has been instrumental in working with coming up with these webinars and clinical insight document. I would also like to thank our AASLD Membership and Mentorship Committee, who's been represented today by Vinay Sundram. So COVID-19 pandemic is having a significant impact not only on the educational experience of trainees, but also raises a lot of issues, including the safety, financial impact of institutions, and a big concerns about the jobs after graduation. Despite the barriers and challenges, this has also provided us with new opportunities and ideas about teaching and also how we provide care. We have to look for positive and silver lining from this pandemic. The COVID-19 cases are increasing in the US, but different regions have been impacted in different ways. Today's panel of speakers and panelists from different geographical locations will share their experiences and solutions during this rapidly evolving time. Before we started preparing for this webinar and which content to present, we did some surveys from our trainees. And first survey which we did on social media was, which of the following issue concern you as a result of COVID-19? And then clearly, the main concern for our trainees were impact on educational activities, and the second was impact on job prospect. There is also a big concern about physician well-being and burnout. I would like to point that in October 22nd, we will be having a separate webinar on physician burnout and mental health. Then we wanted to focus on which educational activity the trainees were more impacted by. And clearly the procedures is one of the big concerns, followed by clinical activity and teaching lectures. So now I wanted to ask, what can I bring Dr. Kardashian to talk about? And also during this webinar, we will, on your screen, you will see some poll questions. And this will be important for us because of this rapidly evolving COVID-19 situation in different regions. We wanted to get a sense that where the trainees are from and how we can use this poll questions during our webinar to answer some question and answers. So we will have a poll question now, and then I will also pass on to Dr. Kardashian for that. So this was the first question that you will be seeing, that what level of training are you in? Internal medicine resident, GI fellow, transplant hepatology fellow, or a recent graduate? So Ani, please take it over and we will see the results pretty soon.
Thank you very much for the introduction, Dr. Hamid, and thank you to the AASLD for the invitation to speak here about my experiences as a trainee during the pandemic. And we see here the results of the poll. So 38% of you are transplant hepatology fellows, 33% are GI fellows, and 29% recent graduates. Thank you for completing the poll. So I have no disclosures to report. And as Dr. Hamid mentioned, I completed my one-year transplant hepatology fellowship at UCSF in June of this year, which meant that the first 8 months of my fellowship training were prior to the pandemic and the last 4 months were during. I'm going to give a brief 5-minute overview of how my educational experience as a trainee changed over that time, with a focus on inpatient and outpatient clinical rotations, the procedural experience, as well as exposure to formal didactics and teaching. I would also acknowledge that my experience in San Francisco was probably very different than my colleagues' experiences in New York and at other institutions in different geographic regions across the country. So broadly, our fellowship curriculum at UCSF is set up so that we have 4 months of inpatient clinical rotations and 8 months of outpatient clinic. On our inpatient rotation, we do both inpatient consults and also work on a primary inpatient liver transplant service. And in terms of consults, to comply with social distancing policies once the pandemic hit, we began to triage which consults needed to be seen in person versus ones that could be performed virtually, which I think really taught us how to effectively prioritize patient acuity. In terms of our primary liver transplant service, our service includes a multidisciplinary team of surgery and hepatology attendings and fellows, pharmacists, social workers, case managers, nurse practitioners, and house staff, including internal medicine and surgery interns. Prior to COVID, the intern or nurse practitioner and myself, or the fellow responsible for the patient, would pre-round in the morning. We would then hold multidisciplinary in-person sit rounds to form our preliminary plans, followed by in-person bedside rounds with the entire team. In early March, we quickly identified that our rounding process was inconsistent with the need for social distancing. Therefore, we transitioned our round to Zoom video conferencing, with every person conferencing in from his or her individual office. After rounds, the attendings would go see patients on their own to confirm daily plans. This rounding process did evolve over the first 4 months of the pandemic. I'd say by around mid-May, we did restart bedside rounds with a smaller team, primarily of physicians, to maximize the educational experience for trainees. So we did see our system workflow evolve to accommodate this new normal. In terms of our outpatient clinics, the fellows transitioned entirely from in-person visits to Zoom virtual visits. Now, this did come with some growing pains. As you can imagine, adding a fellow into the mix creates an additional layer of logistical complexity, given that each case needs to be staffed with an attending. We did ultimately come to a workflow that worked well for both our attendings and for the fellows. So first, I would see the patient in my personal physician Zoom room, and my attending would either wait in the Zoom waiting room or be seeing another patient with another fellow. Once I finished my visit, I would move my patient to the waiting room, text my attending to notify him or her that I was ready, and then bring my attending from the Zoom waiting room into my clinic room so that we could staff the case. Once we finished staffing, I would then bring the patient back into the Zoom room from the waiting room, and we would discuss the plan together. And we really found that this workflow worked most effectively for us. With regards to procedures, in hepatology fellowship, our main procedures are performing endoscopies and percutaneous liver biopsies. At the start of the pandemic, we saw a steep drop off in our procedural volume. And as fellows, we were removed entirely from all procedures to conserve personal protective equipment and also to minimize patient contact. However, once we saw that we avoided a surge in San Francisco and that we had an appropriate amount of PPE, the fellows did restart doing procedures around early May. And this included both endoscopies and liver biopsies. Now, this initial procedural drop-off seems to be in line with other institutions. In a survey of 770 GI trainees across 63 countries in April of this year, 94% reported a reduction in endoscopy case volume. This figure here shows the number of supervised monthly procedures in the 30-day period before and during the COVID pandemic among survey participants. I'd say having already completed GI fellowship, that drop in endoscopic procedural volume was less of a concern for me and for my co-fellows, as we'd already met our requirements during GI fellowship. Luckily, we had also all met our required number of liver biopsies prior to the pandemic, just given the high volume of biopsies we do at UCSF. So that drop off for the couple of months did not, luckily or thankfully, did not impact our ability to meet ACGME requirements. In terms of our formal lectures and didactics, all of our conferences were transitioned into virtual lectures. This provided us with the opportunity to attend more lectures and conferences, in part because we could access them from anywhere. And anecdotally, I'd say I saw greater GI fellow participation in our hepatology lectures during this time. And then lastly, I wanted just to say a word about well-being and wellness in fellowship. You know, the Transplant Hepatology Fellowship year can be a tough year between taking GI boards and searching for a job, all while mastering a very complex field in medicine, and adding in a pandemic really made it harder. I really appreciated that our program director and our associate program director started weekly check-ins with us, which really gave us the voice to provide feedback on programmatic changes, to discuss our educational experiences, as well as any issues regarding safety or redeployment to other services. I also personally found the pandemic to be, during my fellowship months, to be a very isolating experience. So figuring out how to maintain connections virtually with my friends and family, as well as Zoom happy hours with our faculty, really helped to keep me sane and positive during the pandemic. So in summary, while the pandemic has brought on a lot of uncertainty and concern over the hepatology trainee educational experience, it has also allowed us to rapidly implement new avenues for learning as trainees, and we should really take advantage of these opportunities. We now have the opportunity to learn how to use telemedicine, to learn how to bill. We're learning to triage the urgency of outpatient visits and inpatient consults. And we have more opportunities to attend formal didactic sessions with greater ease and with greater accessibility, all of which will hopefully contribute to maximizing our learning experience. So with that, on your screen, you will see our second poll question pop up. And this question is important just for us to really understand your concerns as trainees. And in a moment, we'll show you the results. And with that, I'll pass it back to Dr. Hamid.
Thank you. That was great, Ani. And I would like to have our panelists for this session to open, share their screen, start their video. As expected, that the procedure volume and inpatient clinical training with our early survey and this one again remains to be a main concern. So again, for this part of the panelists, Dr. Teresa Chang, Dr. Allison Fox, Hirsch, and Ani, thank you again for joining. So I wanted to start first with Teresa Yu. So how have you adapted your inpatient rotation to both meet the clinical requirements for the Transplant Hepatology Fellowship, but also prioritizing the safety of trainee, not only during the surge time now in New York when the cases are low? So can you give us a little bit idea about how, as a program director, you have worked on it?
Sure. I think Annie summarized a lot of the issues and changes that had to be implemented during all the changes that have come with this pandemic. And also, as Annie mentioned, it's going to look different from one institution to another, one location to another, and even within the same city. I'm interested in hearing Allison's comments about what things look like over there at Columbia. But I'll sort of outline what happened here during the surge and what things look like as right now coming out of the surge. So during the surge, I think the single most important thing that really helped to keep everybody safe was the geographic separation of COVID versus non-COVID units. And so all the COVID positive patients were concentrated on floors where by having those patients separated out, you minimize the frequency of donning and doffing and help to conserve PPE. And our hospital was almost entirely COVID patients. However, we did maintain a COVID negative floor for our liver patients. And what that looked like for our liver fellows is that it preserved our usual inpatient rotation structure, where we had our liver fellows rotating on pre and post-transplant hospitalized liver patients, knowing that they were COVID-free. Now, our fellows who were on the consult service did see the COVID positive patients on the COVID floors. And what we did for those fellows and that rotation was really kind of going back to the principle of minimizing any unnecessary exposure. And so if you could take a history without going into the room, for example, calling the patient from the other side of the door, you're still seeing the patient, that would be something that would minimize exposure. And then, where a physical exam was required, or we would have the attending go in by themselves. We did try to preserve the one-to-one in-person interaction rounding structure between the fellow and the attending. So the attendings did come in and did walk rounds. And then as things normalized and the case volume went down and we went past the surge, our inpatient rotations look pretty much like pre-COVID. We're going and doing bedside rounds, except that it's with masks and eye protection on. So that's what our inpatient rotations have looked like.
Excellent. Thank you so much. So Ali, coming to you as your role of graduate medical education now, how does the GME helping the new trainees to meet not only their requirement during COVID-19 pandemic, how do you see the future looks like?
Yeah, obviously when the pandemic hit all over the country, and especially here in New York, the ACGME declared emergency status. And what that meant was basically all the rules kind of got to go out the window, within reason, of course. And under that emergency status, the normal milestones and things that trainees are expected to achieve has to be altered just due to clinical demands and also due to, being pulled off of rotations that you were normally scheduled to be on. And so there was some leeway as far as the ACGME goes in terms of completing some of those things. But, because this occurred kind of at a point in the year where there were only a few months left of the fellowship training, which is only a year and it's a precious year, there was obviously a concern that there would be some procedures left or some exposures left that our fellows weren't able to have, and they would have polished off on the last 3 months. I think that we were fortunate because, transitioning early to Zoom, converting our transplant unit into a COVID positive transplant unit, doing things virtually, we were able to allow the fellows in some ways to take on different leadership roles. Although they weren't at the bedside per se, they were able to participate actively in rounds, kind of do virtual consults and really kind of hold down the fort as the attendings became the person who would, kind of run around and see the patients in person. And so I think it was a different kind of learning, but everybody adapted and kind of sprang into action very well.
Thank you. So Hirsch, one of the major concern for the trainees are the procedures so what is your program right now? Are you doing procedures, or there are certain things that you're not being allowed to do? Is there a difference between urgent and elective procedures? So what's going on right now at your institution?
So at Northwestern, we are currently back into the procedure areas, both for elective and urgent procedures. I started my transplant year in July when we were starting to reactivate anyway. And so we're doing procedures on the inpatient side. We're still doing 2 half-days a week of outpatient procedures on our outpatient months. And actually, our program director has encouraged us to use what would normally be a half day of administrative time during our outpatient to potentially reach out to some of the general gastroenterologists and maybe do procedures with them as well. Given that, particularly for me as the sort of pilot fellow here at Northwestern, doing a fast track, my last few months of my 2-year GI fellowship, was compromised in terms of procedure volume, and so just trying to make that up a little bit. In terms of liver biopsies, we are just starting to do those again over the past month or so. However, I think the volume, we just need to bring the volume up a little bit. A lot of them got shifted to interventional radiology during the pandemic. And so bringing them back over into hepatology is something we're working on.
Okay, excellent. So Ani, you brought up a good point about the education activities and the Zoom. Did you thought that because you have done the pre-COVID, educational, and so what are the positives that you got out of or is there any silver lining of the COVID, especially for the conferences and the meetings?
Sure. Yeah. I mean, I briefly touched upon this, but I actually found the transition to virtual conferences to be, I liked that better. I liked the fact that I could learn from, I could choose the environment I wanted to learn in. And, I will say that it does force you to be more proactive, to be more interactive so that you're getting as much as you can from those conferences. But I actually found that it was easier to attend. Could do it from, my couch or my living room. And I really liked that flexibility, and I was able to attend more conferences as a result. So I like that transition.
Okay. And Sharissa, outpatient rotation is one of those more difficult things, especially with telehealth, with no, standardized, supervision, and every place has used different kind of telehealth. What is your program has done, and what's your thought about the outpatient experience of the fellows?
Yeah, that's kind of an ongoing work in progress. We toyed around with the fellows incorporating telehealth into their own continuity clinic setting, and I think it works best with a patient already. So they found that it was something they could use for follow-up visits, but less so for initial consultations. And I have to say, we haven't found a good, satisfying workflow for incorporating a fellow into a telehealth visit along with an attending. There's a lot of that kind of patient dynamic and interaction that you can't replace with a face-to-face visit. And so right now, now that the case numbers are a little lower, people are coming back to the outpatient setting, we actually have our fellows coming to the outpatient setting and seeing patients with us in person.
Hirsch, what's going on at your institution regarding outpatient?
It's something similar. We do a continuity clinic once a week with an attending, and a lot of the visits, I guess maybe 50-50, are now telemedicine versus in person. And so in a similar way to what Ani described in her presentation, for the telemedicine visits, we're actually using Doximity for our patients. And so and on the attending end, we'll be in a Zoom call together, from our respective offices. And then we just kind of mute each other. I talk to the patient on Doximity, and then I hang up, talk to the attending, and then most of the time the attending just calls the patient on his or her own. And then we sort of, touch base at the end of the day. For inpatients, for in-person visits, we are seeing them together with the attending, just as Dr. Chang mentioned.
Okay, excellent. So Ali, what's your advice for our trainees and fellows to remain productive during this pandemic?
Shockingly, I think our fellows actually were super productive during this pandemic. Because we were located in the epicenter, it gave us a unique opportunity to see lots of patients with COVID early on and do something academic with that information. So our fellows actually authored several papers that have been published now on the impact of liver COVID hepatitis and liver injury related to COVID. On other, some of the GI fellows did projects on GI presentations of COVID. And so they really were able to, get large numbers of patients, they analyzed all the data and were able to put it out there really quickly. And so it was actually, despite, having a lot of clinical demands, because it kind of turned into a lot of shift work for many of the things we were doing. They had a lot of time in which they could devote to doing some academic work as well.
Okay, excellent. And Teresa, I have a question about the wellness of the trainees, which is paramount importance to all of us. What are some of the ways your program makes sure to talk about the stress, anxiety, and everything with your fellows during this time?
Yeah, I think as Annie described at UCSF, one thing that we did during the surge was frequent check-ins. So, we would do a group text with the fellows every day on like a daily morning check-in. And we have a wellness champion who's now our APD Cam Hormon, who would do weekly Zoom wellness meetings with our fellows. So I think it's a lot of the frequent interaction to bring everybody back together, because a lot of this part of the anxiety is just the social isolation, honestly. We also try to help offload some of the extra workload that the fellows may have felt during the surge. And so we wanted to maintain some sort of educational conferences, but it felt like a little bit extra for them to be preparing a lecture, the faculty take over some of those conference presentations during the surge. One thing that was, I think, really helpful and important for our fellows was addressing concerns about their job contracts. And this was happening just in the March, April time as they were finalizing their contracts. They weren't sure if they were going to be able, if there was the funding for them to start on time. So we reached out to them and met with them and tried to help, hold their hands the process. We took extra steps with that for our outgoing fellows. I think one thing we're doing now that also addresses some of this kind of isolation is, while it's great having these Zoom conferences, most of our educational conferences are on Zoom, but where we have the working type meetings like RRC recipient review, it's almost like a hybrid. We have a small, no more than 10 people in the room. And there's still something to be said about being, in person, face to face for some of the meetings.
Okay, excellent. So I have a few more minutes before we start the next section. Hirsch, first with you. What do you recommend the GI fellows who are applying for hepatology fellowship? Now, most of the fellowship interviews would be virtual. What would be some of the recommendations for you? How would they evaluate a program?
Yeah, I think that's a great question. And I think rightfully everyone's a bit nervous about this. I'm in a similar position looking for jobs and wondering how that's going to look. Thinking about this, though, I do think there's a silver lining. The first part is I remember interviews are always very nerve-wracking. And to some degree, being able to do them from the comfort of maybe your own home or in a setting where you're not outside of your comfort zone may allow your sort of true self to shine through more easily. And, you may not be burdened by that kind of nervousness as much. The other thing that's nice, especially as a trainee, is you don't have to pay for the travel. So take that for what it's worth. I do think the hardest part is going to be that intangible, at least that was important for me, of sort of the gut feeling that I got when I got to a place and I just felt the environment and the atmosphere. And you're going to miss some of that. But I think to make up for that, use the people at your program, whether it's previous fellows or faculty members who may know other people at the places you're interviewing, and reach out to them afterwards and kind of just have one-on-one calls with them to, ask some of those more detailed questions and get a sense of a feel for the place, I think would be my best advice.
Okay. Ani, anything to add to hers?
Yeah, I completely agree. I think, there's a silver lining with this, saving money as a fellow, which can be great, but also I think an in-person experience is irreplaceable. That being said, taking advantage of other folks at your institution, so either old fellows or graduated fellows or faculty who know faculty at other institutions, just to connect to sort of make that process easier.
And lastly, Ali, just want to finish it up. What is the advice for our trainees and the people who will be starting just as a faculty? What you, as a GME, as a transplant hepatologist mentor?
I think that, liver disease obviously didn't go away during this pandemic. And if anything, so many of our patients stayed home because they were afraid and have come back with a vengeance, so to speak. It feels good to be getting back to a new normal, I think that we are, full steam ahead with inpatient and outpatient activities now. And although things, have changed quite dramatically, we really are doing the same old thing, just in a mask and a face shield, as Carissa pointed out. And so I think that, things, we will persist.
Okay. Thank you, all of you, for such a great and lively discussion. And now we would gonna go to our other very important and second part of the talk. So I would have everyone, including myself. So it is my honor to introduce Vinay Sundaram, who is the Director of Hepatology Outcome Research and Associate Professor of Medicine at Cedars-Sinai Medical Center. And just like the last time, there would be some poll question who would be just showing up soon. And that the first question is, which of the following most concern you regarding a career in hepatology right now? Lack of job availability at an academic institution, lack of job availability at a transplant center, lack of job availability in a location where you desire to live, or reduction in federal funding to support a research career. And the results will show up soon, but I would like Vinay to take it over and discuss the result when it would be available very soon. Thank you, Vinay.
Thank you for that very kind introduction. So what I wanted to do is talk briefly about the impact of COVID-19 on hepatology practice and job prospects. And of course, here we see the results of our survey, and it looks like the majority of people were concerned about job availability in the location where they desire to live. And we'll be happy to discuss that in the Q&A. These are my disclosures, none of which are relevant to this talk. So there is a high clinical demand for hepatology, and I think that's apparent. And recently, the AASLD Training and Workforce Committee wrote a paper with regards to assessing the current as well as projected future demand for hepatology in the United States. There's an estimation of 4.5 million adults with chronic liver disease, and despite significant advances in the treatment of hepatitis C over the last few years, the prevalence of liver disease is expected to rise due to a combination of the obesity epidemic as well as the rise in alcoholism. And unfortunately, that does lead to an increase in liver disease as well as the complications of liver disease. Therefore, the AASLD Training and Workforce Committee performed this study to assess the current and future demand for hepatology. What were the main findings? Well, first, the prevalence of liver disease is expected to rise by 33% between 2018, when they started the paper, to 2033. And this is primarily driven by a rise in the incidence and prevalence of non-alcoholic fatty liver disease. Subsequently, there's expected to be a significant and widening deficit in the supply versus demand of both adult and pediatric hepatologists over the next 15 years. And in particular, it's been well established that fatty liver disease affects children. And so therefore, there is going to be an increasing demand for pediatric hepatologists, not just adult hepatologists. And finally, there's going to be an expected maldistribution of hepatologists. And what I mean by that is that the majority of hepatologists end up getting a job at an academic institution or a transplant center, which the majority are located in urban areas. And as a result of that, the more rural areas where there still is a very high prevalence of liver disease may not have access to hepatologists or people with subspecialty training in this field. And therefore, there's going to be an increasing demand in the more rural areas of the country. This is a table which looks at the projected demand and the deficit of supply relative to demand. And I just want to focus on the last column, which shows that by 2023, there's a 10.1% expected deficit. And then in 2033, which is only 13 years away, there's going to be an expected 35.1% deficit. Now, that said, coronavirus has thrown many things into disarray, and that includes the healthcare system. And unfortunately, despite the fact that the number of patients who are entering a hospital have increased, there has been a decline in hospital finances, particularly in rural areas. So a study was recently published in Gastroenterology. This was a survey of 73 centers across the U.S. and Canada, and the responses were submitted in March and April. So what were the findings here? So with regards to changes in endoscopy, 65% of the centers were operating at less than 10% of their volume, and 25% were operating at only 25% of their volume. 97%, so virtually all centers, had postponed elective procedures, including screening colonoscopy. And this is the plan for the respondents in terms of what were they intending to do to address this. And the majority of centers actually had no defined plan at the time of the survey. Now, in terms of clinical practice, 55% of centers had partially closed and 21% of centers had fully closed their clinics, though I'm certain there's been a recovery in that. At the time of this survey, the majority of centers had changed to operate such that more than 75% of their clinic visits would be by telemedicine. And that's further illustrated in this graph, that again, more than 75% of clinic visits would be in the setting of telemedicine. So ultimately, what does this mean for our field? Well, regardless of the impact of coronavirus on the healthcare system, that hasn't changed the demand for hepatology, which remains high and is going to increase. And in addition to that, there are certain aspects of this field which seem to curb the impact that coronavirus has had on finances. In particular, our field is more office-based rather than procedural, and clinic volume can remain high, particularly due to telemedicine. At our institution in particular, our work RVUs actually increased compared to a year ago when we looked at our academic year. And that's due to the fact that not only can we see these patients by telemedicine, but in fact, our volume is growing because of the fact that patients don't have to drive from their house, and therefore they can have access to a physician much more easily. In addition to that, although we saw an initial decline in liver transplants when the coronavirus first hit the Los Angeles area, in general, that also has seemed to recover, and we'll talk about that in a little more detail later. But because of the fact that liver transplantation is not an elective procedure, but a life-saving surgery, transplant volume is likely to remain stable based on the expected need. And I will end my discussion here, and I will turn it over to Bilal. Thank you very much.
Thank you. That was great. There would be another question that will gonna show up, and I would also meanwhile ask the panelists for this section to start their video and unmute themselves. So before we start the question and answer, let's do the poll. Which of the following most concern you regarding are searching for a job, reduced ability to network with colleagues at potential places of employment, having to interview a position virtually, or inability to visit or tour an institution in person. So while we wait for the result, I would like to introduce some of the panelists. Thank you, Annie and Hirsch, to be back. Dr. Jorge Marrero, the Director of Liver Transplant, and Eric Israelian, who is our GI Chief at UCLA. So this was the results. Obviously, inability to visit an institution in person carries 57%, reduced ability to network with colleagues, and having to interview virtually. So, Eric, this is a very, distressing time for a lot of our colleagues and especially our fellows. So how has COVID affected the hiring of recent fellows for faculty position or physician scientist faculty tracks?
Well, first of all, I just want to say this is such an outstanding presentation. I wanted to thank all of you for inviting me. And I think, well, obviously it's been devastating for the entire planet, and the financial ramifications for universities have been significant. I mean, we are part of University of California system, and obviously UCLA in Southern California as a major public research university has been affected by COVID-19 for so many reasons. The university itself has been affected because we don't have students on campus. So you don't have residence hall revenue, you don't have dining hall revenue, you don't have stores on campus, in addition to all the decreases in volume that occurred when we had stay-at-home orders and people were concerned about seeking healthcare. Now we've come back very strong over the last couple of months, and so that's been really reassuring in terms of, I mean, I think we're busier than ever now, and I think we're back at pre-COVID levels in terms of volume. But one thing I'll say is that we made a commitment to continue our recruitment efforts, particularly in hepatology at UCLA. So we've recruited 3 physician scientists, and I think provided generous packages to them. Maybe they don't think it's generous, but I think it's generous. But I think giving them an opportunity to launch their careers, and it's just part of our mission. I mean, one of the things, again, as a part of an academic university, public university, our goal is to be a leader in research, training, and education. So I think we look at some of these kind of positions as mission critical and not luxuries. I do think that on the clinical side, there are areas where different programs and different specialties have had to make adjustments because of the realities of revenue. And as Vinay said, I mean, the hepatology is a little bit different than general GI because of the approach to patient care. And if you think about liver transplantation as one big category within hepatology, liver transplantations have to continue. I mean, this is, liver failure hasn't stopped because of COVID-19. So for many reasons, I think hepatology is still going strong, and I think it will continue to go strong. But I think, for trainees out there, my advice is to really look at programs that are also in that growth phase, especially if there's a challenge in terms of finding positions, to identify areas that really need to continue to grow and may need your services, because they're not going to pull back because of a few months of the pandemic.
Thank you so much. Jorge, a lot of our time that ASLDs used to be the main time when the fellows are meeting with the faculty. So what's your advice for our current fellows when to start the job search during this COVID-19, since most of these meetings that they go are including ASLD are now virtual?
Yeah, that's definitely a change at the moment, given that there's no DDW, the annual ASLD meeting, the ASTS, and all these transplant meetings. I think my advice is the first step is talk to your division chief of hepatology, program director. I think a lot of the job opportunities are not posted publicly. Mm-hmm. So your division chief of hepatology, and all the leaders may, and even transplant surgeons may have information about potential job opportunities that are not publicly. So I would do that first. And then, the ASLD has a lot of potential or a lot of significant resources like a career development center, career center, career development awards for the researchers, the SIGs, the specialized interest groups that you can participate, like in liver transplant, liver cancer, et cetera, that you can meet leaders in the field. So there's going to be a virtual meeting. I guess you can see who's speaking, and then you can interact. So I think, yeah, it's how you conduct a search, a job search is a little bit different now, but there still, it requires reaching out to people, whether you're in a face-to-face meeting during DDW or virtually. Having gone through a search recently, it takes a lot of patience. The job interviews are going to be taking longer. You don't have those boluses of 1 to 2 days meetings with all the leaders during the job search. So it will require a little more patience, but it's still, people are accessible and you can email and reach out. So
Excellent.
That would be my advice.
Thank you so much. So Hirsch, what is your plan?
I have begun doing some of the things Dr. Murrow mentioned. I've been sitting down and meeting with our chief here, our director of hepatology, my program director, and really, frankly, all the faculty here to, just get some of their advice and, understand the places where they may have connections or know people. And then, again, as Dr. Murrow mentioned, I think the plan is just to, reach out to the places where I'm interested and express that interest and hope for the best. One of the biggest lessons I've learned through all this is that adaptability is key to survival anytime and anywhere, and the same goes true for now. And so I think you just have to adapt to the times and have positivity that will work out.
Excellent. So Vinay, that document, the task force paper is such an impressive paper, and I would encourage everyone to read that. So what do you advise about, you mentioned about the disproportionate areas what would be advice for the trainees and, people who are interested in hepatology look for going forward?
Sure. So it's interesting because the number one concern among the attendees here was not finding a job, but finding a job in a location that they desire to live in. And so that component of the job search can be tough, and that's regardless of the presence of COVID. I remember when I got my first job, which was in 2012, my wife only wanted to live in Los Angeles, and so I ended up taking a job which was not a good fit, and then ultimately I found my way to Cedars-Sinai. But the initial job would have actually been, a very poor fit for me and would have made me very unhappy. So some of my advice, number one, is to, I know that location is important, particularly when you have to consider family. And if location is the number one thing, the number one priority for you, what I would strongly consider is to do a transplant hepatology fellowship in the city where you ultimately want to work, or in the location where you ultimately want to work, because no interview for a half day or a full day or whatever can replace a job interview by doing a fellowship at that institution. And so it'll increase your chances of getting a job at that institution where you're doing the fellowship, or it will increase your ability to network within that particular city, because the people at that institution in that city will know the other hepatologists very well and can give you a strong recommendation. Now, in terms of getting a job here, though, that should not be a problem because the demand is very high. It's just a matter of where you choose to practice. The other thing to consider is whether or not you really want to practice in a transplant center. And obviously, as everyone has done transplant hepatology training, that's probably the goal in the majority of cases. But if you prefer to do advanced general hepatology with the possibility of managing patients post-transplantation, but you don't necessarily want to be, or don't necessarily need to be part of the evaluation and the monitoring process during the listing component of transplantation, there is a lot of demand in rural areas. You can find GI practices where they will hire you as a hepatologist because there are so many hepatology patients that the general gastroenterologists prefer not to see. So it's a matter of kind of figuring out what your career goals are. And if location is not as important, there's probably transplant hepatology jobs available. And similarly, if you don't have a strong desire to practice transplant hepatology at a transplant institute per se, but are considering going into private practice, there's probably some opportunity there as well.
Excellent. So Eric, with the financial situation you mentioned earlier, if you hire someone new as a GI chief, is the expectation for the division would be different either financially or RVU targets or the goals? And if you hire someone for research, they have to do more clinical work based on what we're seeing during the COVID time?
Well, I mean, at our institution, that's not really the case. I mean, what we try to do is put people in the maximum position for success. So we hire, physician scientists to be physician scientists and clinician educators to be clinician educators. And, the clinicians are heavily incentivized to, be productive in terms of their clinical care. As I mentioned, there's a huge demand for both general GI and hepatology, like Vinay was saying. So we're not seeing a shortage of volume. We dealt with some inefficiency for a few weeks, particularly when we were minimizing kind of non-emergent procedures and ramping up COVID-19 testing. Now our testing is so robust that it's really not an issue. We just make sure we test every patient before they come for procedures, and we work with all of our societies in terms of trying to make sure that we have our safety measures in place for our patients and for our providers. So now that that's the case, we're kind of back in business, so to speak, with respect to general GI and hepatology. We are utilizing telehealth quite a bit, but I think we're now seeing a shift towards more in-person visits across the system. So I think we've been trying to prepare faculty for life post-COVID as well. I think the biggest challenge for all of our faculty, particularly the research faculty, is just the financial tail with respect to the crisis. So you're going to see I believe with government and extramural funding agencies just having a lot more difficulty with funding because of lack of revenue. So you're not going to see huge amounts of revenue going in through taxes because of the situation in our country. So I think it's going to be difficult for regulatory bodies to say they're going to increase their research funding. So we just have to kind of prepare fellows and junior faculty for that on the research side. And on the clinical side, I think it really is going to come down to making sure that people are efficient and are put into situations for success. And I also agree with what Vinay is saying. I think for trainees, they have to think about their long-term goals. And there's a lot of delayed gratification, obviously, in gastroenterology and hepatology, especially if you do advanced training. So everybody who's been doing that is used to being patient and working really hard and being kind of at the top of their field for a long time. And I think you have to find the right setup for you. I think many people who are a little bit more senior probably didn't have every single item ironed out when they first took a job. And I think a lot of younger trainees who are graduating now are kind of expecting to know, where am I going to scope? Where am I going to be? Where will I be on a Thursday afternoon, Friday morning? I just want to know exactly what I'll be doing 5 years from now. Well, we don't even know what's going to happen to the planet 5 years from now. So I don't think that that's the way you should approach a job. You should think about, looking at things in chunks and being able to kind of set yourself up for the next step if possible.
That's such an thoughtful, and it's great for the trainees to hear about these suggestions and ideas. So Ani, with the virtual, the liver meeting, do you have any advice for the fellows about what they can use the opportunities during the digital liver meetings for networking?
Sure. I definitely think it's unfortunate that the liver meetings not in person this year. I felt like the liver meeting for me last year was like a 72-hour long interview. It's just like meeting with so many people. And I think in some ways having that in-person interaction is so valuable. But, in the absence of that with our digital liver meeting, I still think it's extremely important to be reaching out to the programs and institutions where you're interested in looking for or getting a job before the liver meeting. And I found that the most effective way to reach out to other institutions was through our faculty. So having faculty at my institution reach out to faculty at institutions I was interested in. And I felt like that really helped to make the connection. It was really, that's sort of what established rapport. I'd also say that, despite us not being able to meet in person, setting up Zoom meetings and video visits or video meetings is more effective than telephone calls. I think just seeing someone's face goes further than a phone call. So, when we're not able to be in person, I think the second best alternative is some kind of video meeting. And also being persistent. I can't speak to how important that is as a fellow. When you're looking for a job, it's not like a fellow, applying for a fellowship program or a match process. It's very, very different. And for many of us, it's the first time we're actually getting a job. So it's really important to be persistent. I would email programs every month to see if they had availability and just really continue to reach out to programs.
So Jorge, it's not like, doom and gloom with the COVID-19. So what is what you see as the future of hepatology, and what are some of the advice you want to see all the trainees who are listening to you right now?
I certainly don't think it's gloom and doom. I think this is an opportunity. I think what the pandemic has highlighted, or the opportunity that the pandemic has brought to the forefront, is being efficient in the delivery of care. Now with telehealth, and it happened overnight, at least in our center, we had no telehealth, very little, and now it's being incorporated, and we had plans to use it, but now, our volume is really up to pre-pandemic, both in hepatology, transplant, and so we're really humming in that aspect. So delivery of care, it brought to the forefront the pandemic, racial inequalities, gender inequalities, ethnic, and I think there's an opportunity there for a young person to study that and develop a career highlighting or studying these disparities and provide interventions for them. And I think there might be funds available for that aspect. So I think in the other part is because in places like Texas, where the geography is such that, we have clinics all over the state. So we need hepatologists to go to different clinics. Now, we're using telehealth at the moment, but given the disparities or the need for hepatologists in rural areas, I think the advent of technology and maybe potentially hiring more people so we can provide the care to those rural communities in such a big state like this, I think, there's still manpower and we need more people. So I think there are opportunities to innovate in how care is delivered, who needs more endoscopy, who doesn't, and try to streamline care in that fashion. So I think there are huge opportunities to rethink how we deliver care, and so I think that's a huge opportunity, I think, for the future.
Thank you. Excellent. So we have a few more minutes. Winnie, what are the mentorship committee and other about the ASLD opportunities for the trainees this year?
Sure. So first, just to go back quickly to Ani's point about advice for finding a job, I can't agree enough about persistence. And the other thing to note as well is the importance of word of mouth. And I think when it comes to hepatology jobs, word of mouth still carries a lot of weight, such that if there are people who as part of your faculty or your division chief who can put in a good word for you, that can get your foot into the door much better than you emailing a division chief or a medical director yourself. Now, in terms of what we have at the liver meeting, we have the ELS scholars and career development. So we have a career development workshop. We're going to have a virtual town hall, and we'll also have lounges for all of the different SIGs. Each SIG that we have is going to have their own virtual lounge, which will be open from 8 to 5 or during the business hour meetings. But in addition to that, I had a conversation with Colleen and John this morning. And the other thing that we're planning on arranging is the ability to do virtual private meetings, meaning that if you've logged on to the AASLD website for the liver meeting and you plan on meeting somebody at a certain time, both of you log on and then you can request to do a video chat with each other, and then the two of you can privately chat, or if you want to make that more than two people, you can do that. It's not going to be the same, of course, as an in-person meeting over coffee, but we are trying our best to replicate the situation in a very unusual time. So definitely take advantage of that if you've reached out to faculty members at prospective places of employment, to take advantage of these virtual private meetings that you can have.
Excellent. Thank you for working on this important part for trainees during AASLD, and I encourage all the trainees to register for the meeting. So last question, Eric, what is your advice now for as a GI chief about for our future, trainees and for the future hepatologists?
Well, I think that the future is definitely bright. I think this is an incredibly dynamic field. I think that the pandemic has obviously created or magnified some stress in different pockets of the country. And I think for trainees, they should look at kind of the stability of the organization if they're looking to kind of put down some roots for a while. It's challenging to try to get a sense of that, but you can kind of see, is there a lot of turnover in an organization or in a division? Does it seem like there's any stability in the leadership? Does it look like they have resources and support outside of that specialty? Because that's one of the things that I've encountered with talking to other chiefs elsewhere, is many people have been looking to move around, just because even though they're strong, their institutions have put a lot of pressure on them individually, and so they're looking for opportunities elsewhere. So I see if that is what I see from chiefs, then I think that it doesn't bode well for the whole system. So I think for trainees, you want to really kind of do your homework, talk to people who have been recently recruited, talk to people who have been there for a while, get a sense of what do they feel about the system. Because the last thing you want to do is take a job that's mainly clinical if your goal is to be a physician scientist, or vice versa. Take a job that expects you to be publishing in high impact journals and get independent funding if your goal is really to take care of patients. So I think it's, get a sense of what it is that would make you happy, and make sure that there's a match there.
Excellent. So, there's some other questions. I know that we are over the hour, but we still have good number of participants. So, Jorge, how does the potential faculty look at the program? Because most of the interviews would be virtual. So how would they find out about the program? And our programs will do something to promote there if they want to hire faculty?
So, I agree with Eric, what he just said, what he has said. So, a lot of the job search, I think you have to look at the stability of the program in terms of the liver program and the overall institution's health. Did they cut everyone's salary or they did not, and so forth. And so I think that's very, very important. What is the turnover in terms of at a specific location? But I think what my advice would be is to look at, before looking for a job, you need to know what you want, and whether a physician scientist, a clinician educator, or whatever other role. So then look at what each program in the specific role that the person wants. Then, okay, what is the strength here? And how are they treating people? Talk to the young faculty, as Eric said, or the established faculty, and so forth. So to me, it's all about reaching out and study the programs well, the volume, the liver transplant volume, the leaders, the how many mentors are potentially available, how many young faculty have developed, and so forth. So I would look at different aspects personally.
So Vinay, with the about the academic versus transplant, hepatology position versus private practice. What are your thoughts? What does the trainee, as a trainee, you think about when you're looking for all the options that are available?
Yeah, I think, again, the primary thing is to figure out what would make you happy and also what would make your family happy. Certainly, if location is the most important thing, then you may need to compromise what the ideal job would be for you, so in order to be able to live where you need to live. But you have to think about, do you want to take care of patients? And if so, do you really want to manage more critically ill peri-transplant patients, or are you more interested in general hepatology? Are you more interested in having a niche with fatty liver clinical trials, for instance, which a lot of private practices, including private practice hepatology, are doing very well in? So I think that's the take-home point with which a lot of the other panelists have echoed, is that really, think about what it is that you want out of your career in the next few years, but also don't plan your job around what you expect is going to happen 10 or 15 years from now. Rather, will this job get me to the next, or, will this help me get to the next step or the next level? Because your first job very rarely is going to be the perfect job. So just think about those things, but do realize that there are a lot of opportunities throughout the country to be a hepatologist.
Perfect. And lastly, Hirsch, what's your about the job, and what do you have some ideas right now about the academic, private versus transplant hepatology? How are you thinking about it?
Excuse me. As was mentioned a few times, I think what's been important for me over the past few months has been really sitting down and critically thinking about what I want to prioritize. I have a 1-year-old, and so being near family is important to us. And so if that's going to be a priority to us, then perhaps I might need to broaden, the settings in which I'm looking at working in. And so, I'm trying to come up with a list of those priorities and sort of rank them in my mind to then be able to, tailor my search in such a way that it meets those priorities. And as Dr. Sundaram mentioned, I know that, some of these, there's the potential that maybe my first job, I may need to change my outlook or adapt my views a little bit to be able to find what works right now at this time.
So with this, we can end this. Thank you so much, because I think this is such an important thing for all the trainees. And I wish that, when I was looking for a job, I'm so far lucky to be happy in my first job, but then it would be very helpful. And so I would like to thank all the panelists who joined and take their precious time to talk to us. And I would also like to thank our ASLT staff, John, Colleen, and Katie, for all the work they have done behind the scene. And this will be again available on Liver Learning and ASLT website. Thank you, everyone. This would be the end of our webinar. Have a good rest of the good night. Bye.
Bye.
Thank
Bye.
you.
Thank you.
Bye.